Welcome to Curitics Conversations, a conversation with leaders who spent decades building, operating, and reshaping some of the most complex parts of healthcare. Today, we are joined by the great Sam Wald, CEO of CareMore Health. Sam has spent years operating at the center of value-based care, population health, and Medicare Advantage, helping lead organizations focused on improving care delivery for complex populations while navigating the operational and financial realities shaping healthcare today. A big part of today's discussion is going to focus on what healthcare execution actually looks like behind the scenes, particularly as organizations face increasing pressure around margins. We like to call this, Sam, the new age of austerity, especially in government programs. And we know you'll have a lot of insights on that. So, Unmesh, a quick word, please, before we ask Sam to introduce himself.
Absolutely. Well, I'm very excited for this episode. I've known Sam for years now. Um, with his background at Healthcare Partners, Davita, before that Scan, then going into Optum, Monogram, where we were working together quite closely when Sam was leading the California market, and then Wellbe and now CareMore. I mean, Sam's seen early days of value-based care
Yeah.
to how it has evolved, and there's so much talk about folks who want to solve all things value-based care, but we would love to have some practical dialogue today on how Sam sees the world with all these in the age of austerity, like you said, John.
Yeah,
So
absolutely.
excited for this conversation.
So, Sam, we'd love to have you introduce yourself in your own words and share a little about your background and the work you're focused on today.
Yeah, absolutely, and pleasure to be here. And just a ton of gratitude. I'm sure we'll get into it, but I've been very, very blessed to be surrounded by amazing leaders who have helped shape my views and my journey as we enter into the age of austerity, which I like that description, and I count both of you among that. So a real privilege to be here. Unmesh, I appreciate sort of the overly rosy welcome. A little bit about my background. I have been in value-based care going on, boy, it's 18, 19 years at this point. And, before that, I cut my teeth as a practicing attorney. So that was my first journey in life. When you want to save the world, what do? You go to law school and spend about 3 or 4 years practicing law and realized that there was a higher calling, for me, and feel very, very fortunate to have found value-based care, which I just am truly passionate about. My professional career history within value-based care has predominantly been on the provider side, helping PCPs and providers take global risk and really take full accountability for patient populations. And it has spent some time on the traditional payer side as well at SCAN.
It's a long, strange trip you've been on, Sam. And,
By the way, I'm a huge Grateful Dead fan, so you made my heart very happy with that quote,
there
John.
you
Thank you.
go. I
Yeah,
thought I knew that about you.
yeah.
But also to say that you walk in a valley of giants. I mean, you have worked for some of the huge titans in this industry, like Dick Merkin at Heritage. You worked with Jeff Kong at Wellbe, and now in the shadow of Liba Lesson and Sachin Jain at Caremore. And
And
you've had the
Dr.
opportunity.
Zinberg, Shelley Zinberg as well.
Yeah, yeah, absolutely. And you've had the opportunity to see healthcare from just about every side of the industry, which is very unusual for a lawyer, by the way. You've done operational leadership, you've done care delivery, you've done value based care, you've done payer provider collaboration. Having been on just about every side of the fence here, what are some of the biggest success stories or operational approaches you've seen actually work in improving care delivery and outcomes, especially, I mean, your monogram experience here is hugely important for complex populations in particular.
Yeah, and I think you nailed it with starting with complexity. When I really stop and think about, hey, what differentiates successful operations, successful clinical delivery, I think having a healthy dose of respect for the complexity really goes a long
Yeah.
way. It's hard to understate what it means to treat a patient that has 7 or 8 chronic conditions, that's in and out of the emergency room, that has, myriad social determinants of health gaps that need to be closed. And, I'm sure you'll ask at some point, but I'll lead with it. Like my biggest piece of advice to folks, if they really want to experience it, is to get into a senior folks clinic or go do a ride along for a home-based provider like Monogram. And when you really witness that, you'll see it's an enormously challenging job to be able to deliver care in a coordinated fashion. And the ones that do it most successfully, to answer your question directly, John, I think are the ones that are ruthlessly prioritized against what are the most important things that we can do. And you have the courage to say, hey, these are the 3 things we've got to do, and we're going to let everything else go. And that's the way you sort of combat that complexity, that sort of entropy that sneaks into the system.
Well, value-based care is such a unique area of healthcare and is considered to be like the next thing, right? If we do it right, then we can actually have great outcomes for everyone in the healthcare ecosystem. Easy to get in, but hard to stick along that path. And over the years, you've been on this path in various different settings. One, what drew you into value-based care? And two, more importantly, what kept you going over the years?
Yeah, I appreciate you asking that. What got me in, like I said, I did come to value-based care as a second career. And for me, it was this opportunity that sort of started to take shape in 2008, 2009 with the ACA. And this idea that we had, a fundamental opportunity as a society to start getting the way that healthcare is delivered and experienced specifically for high complexity, high acuity patients just on a better track. And I'm just one of those true believers about value-based care. Like I believe in the model. I believe that when it's done right, there is no better system. And it's become a bit of a calling for me. It's certainly, my passion. And I suppose, that takes it into your second part of your question of what keeps me going, which is I love it. And I find it endlessly fascinating. You know, we talk a lot about product within the healthcare delivery space. And I've always believed that we overcomplicate it. And, the product at the end of the day is a patient in front of a caregiver. And the way that you can take that simple product and then create just bounds and bounds of complexity against it is just a very interesting puzzle to solve. And it really keeps me going.
Mm-hmm. That's wonderful to hear that
Right.
you're still, at this point in your career this long, Sam, that, the patient is still very much at the center of your focus. And that's where it's at. I mean, certainly in this environment we're in now, specifically in Medicare Advantage, which has always been a core of the business for Caramore, right? We knew 15, 20 years ago, most of the companies in Medicare Advantage were printing money because, risk selection was working somewhat. And today we know that, more than half of the enrollees in Medicare Advantage have the multi-morbidity crisis, which is, they have the trifecta of diabetes, cardiovascular disease, and chronic kidney disease. And I know that's always been at the core of what you did at Monogram. I'm sure you saw tons of it at Heritage and at Wellbe as well in the adult daycare centers that you guys operated there. What this is really as things tighten up in Medicare Advantage, I think this is really where the rubber's going to hit the road. And we're looking at rates starting next year that won't even keep up with the rate of medical inflation. So what are some of the biggest challenges and solutions that you see around multi-morbidity, especially in Medicare Advantage?
Yeah, it's a tight environment for sure. We can debate V28 and sort of overall policy around risk adjustment and rates. At the end of the day, I think the thing that I believe the most is clinical outcomes, and differentiated clinical outcomes will win the day. And when you think about that and you put, not just CKD, CHF, and diabetes, but you throw in COPD, you throw in other ambulatory case sensitive conditions that end up in the hospital, bouncing around emergency rooms. One of the solutions that I really look for is not just keeping the patient at the center, but it's actually getting back to putting the provider at the center.
Mm.
I'm sure we'll talk about technology and some of the amazing work that folks like Unmesh are doing in the AI space. But at the end of the day, that product is still that physician, that NP, that social worker taking care of that patient. And finding ways to make sure that that provider can do the right thing for the patient at the point of care, I think is increasingly becoming one of the most important things that any healthcare services organization can do. And if you do that well and you get those clinically differentiated outcomes, the system works. And I think, look, you know better than anyone, John, we're a cyclical industry and rates are going to rise and fall, but that's what's going to win the day.
And those are the fundamentals that'll get you through.
That's
So
exactly
what does that look like for you at CareMore now, and working with the heavily capitated environment that you have in California? What does that actually look like on a day-to-day operational clinical basis?
I
How is
think
the model different?
Yeah, I think for us, it starts with intentionality and really not just saying, hey, we're going to put the provider at the front and center, but actually taking actions against it and having the discipline and the rigor to check ourselves as we go along. And you can do that through engagement surveys. The best thing to do, what I do quite often, is just get into the clinics and talk to the providers. And if you sort of have that customer focus and you build, call it servant leadership, call it what you will, but this idea of like, hey, we're here for the doctor, we're here for the NP, we're here for the patient. That's what we're trying to bring to life within CareMore. And as you mentioned, I mean, CareMore has such a rich history of doing this well. And so much of what we're trying to do is honor that legacy and get back to that type of model where, we would do anything, quite frankly, for the provider and the patient. And that's what we strive for each day.
Absolutely. I mean, you can see it in the culture, and it's been all over that company since its inception, and it's just wonderful to see Liba and then Sachin, really maintaining that as the culture. I mean, of what CareMore is all about. What does that look like from a care delivery model standpoint, though? How's that different?
I don't know that it is different. I joke with my team, I'm just a simple operator. And not only that, I'm not a physician. I'm not a clinician. I tell folks all the time, I'm not the one who has to discharge a patient from the ED or titrate meds or make the difficult call on when to start having end-of-life conversations. My job is to enable our providers and caregivers to do that. It's a back to basics approach. We lean into, hey, we don't have to reinvent anything here. The model has proven to work. What we've got to do is bring a differentiated focus on doing the basic things right. And if we do that, it's the beauty of value-based care. Like, you'll get the right outcomes and you'll get the right business results.
Yeah, yeah, absolutely. Thanks, Unmesh.
Yes. Well, Sam, I think value-based care, data is so important in value-based care. And especially when you're running a multi-payer provider operations where you are working with different payers, integrating data feeds from them, concatenating them in one place, normalizing them, and then extracting information that you can position in front of your operators and clinicians. How critical do you think the role of data is? And then how do you see data aligned with operations and clinical teams to really drive value-based care forward?
Wow. Could we go back to John's questions? His were much more in my wheelhouse. I mean, look, Unmesh, obviously any successful organization is going to have to be data-driven. We put a lot of stock into what we call data literacy. And what that means for us is making sure that we're making the data available, democratizing it, and getting it to the people who need it the most. And it can feel a little counterintuitive because the deeper down in the organization you get, the simpler it has to be. And you can have this disconnect at higher levels of the organization where it's, hey, we've got all this data, it makes perfect sense. But if you don't take that data and actually translate into this is the insight, this is the action, you're not gonna move the needle. And so we spend a ton of time, working with smart folks, you included, on, hey, how can we do that better? It is an area within like the delegated model of California and other parts of the country that I think continue to pose a bit of a challenge, which is there's still, data that the payer holds. There's data that we as the provider have on a more real-time basis. And then how do you take that, combine it to not only treat the patient at the point of care, but to make sure that that data is being transmitted, you're getting your gaps in care closed, you're capturing, the appropriate conditions, and the full cycle is sort of happening. And it can feel daunting. I think we've made extraordinary strides. I mean, as I reflect on the last, 15, 20 years, the data that we have available now is, I think, fundamentally more meaningful than what we used to have.
Hmm.
Yeah, and one thing which was really fascinating I was talking to your CIO, is as you guys define the user experience and patient personas and provider persona, a big part of that is the office staff and the front desk. And it was a fresh breath of air to listen to how much focus you guys have on the front office staff and the people who are actually scheduling and preparing the information before the patient show up, or even something as simple as calling folks, by, the clinical risk and engaging them. And it was great to hear from your team when I was talking to them last, how much focus you guys have on that area, which is
Well,
very
thank
exciting.
you from the bottom of my heart for saying that for a couple of reasons. One, I'm incredibly lucky to have the team that I have. You know, it's a wonderful group. We're focused on the right things, and I pinch myself each morning that I get to work with the team that I get to work with. And two, it's good to hear that sort of our maniacal focus on workflow and hey, how is this going to impact the person who has to do the job is sort of carrying through. That is something that I feel like consistently gets lost, especially when you talk about data or technology. And we really do try to have that intentionality of, okay, you know, how put yourself in that front desk, put yourself in that MA's shoes. How is this going to manifest? How are we going to make sure that, the workflow with the data is going to end in the result that we need it to?
That's right.
It seems like perfectly situated for the moment we're in right now, Sam, especially with, as you mentioned, V28 and, some of those reforms moving forward. It certainly seems like regardless of who's in the administration, we're going to see this regression to the mean on risk adjustment. And that makes the Medicare Advantage game really about star ratings. And we all know at this point that star ratings is now really about the member experience. And we know that the member experience is really about what happens in the provider's offices. And so I'm interested in like how you work with your provider partners on these specific star measures, especially around the member experience. I've worked on boards of plans that, we lost a half a star rating because of two members.
Two
Like,
surveys, right?
yeah. And it's like you miss by just one member in one measure. And in that case, it cost us almost $20 million. So how does that work its way into, the intentionality you keep referring to? And the empathy you just expressed for how this would work at that front desk, or how this would work for that nurse practitioner in the office once the door is closed. Like, what kinds of information are you providing your providers so you can impact those kind of scores, and what do they do with it?
Yeah, it's a tough area. And I think, again, thinking about the delegated model and sort of that bifurcation between payer and provider or payvider, when you think about CAPS and HOS, it's tough. I'm not probably the most familiar with current state of how they do the cohorting and choose the surveys, but it always felt like a little bit of a black box from a provider
Hmm.
side. For us, and I'll speak a little bit about the IPA here. One, I'm a firm believer in the model. I think the IPA is an amazing healthcare delivery system that allows independent practitioners to stay independent and be supported and, bring high level of care to patients who otherwise wouldn't get it.
Yeah.
And when you're working with a network like that, the most important thing is to focus on what you can control, which is, hey, what data points do you have? Like, again, this idea of democratizing data. And when it comes to CAPS and HOS and experience, what are you going to do to stand up patient NPS surveys? What are you going to do to identify, hey, here are the, two or three, not 30 or 40, but here are the two or three things that we think are really going to move the needle should a patient get a survey. And then having a team that can go and meet the providers where they're at, because these are providers who are running a small business essentially, and say, hey, this is what we can provide to you. This is the service that we're going to bring. This is what we really suggest. How can we help you implement this? I think is probably the right approach for an IPA-based network. It gets a little bit, I'll call it easier. It's still quite challenging for, high-risk clinics or group model, where you should have more of an influence on the overall flow of the office and experience. And then, probably the last thing I'll mention there is really paying attention to your referral network and your specialty network.
Mm-hmm.
We rightfully spend a ton of time working with our primary care physicians. But as you think about quality scores, where the puck is sort of moving to, getting aligned specialty partners, referral partners who can help in that, my understanding is it's becoming incredibly valuable. But I'm curious, your take, John. Like, are you seeing that from a plan side as well?
Yes, sort of lot of plans, especially in the middle market, late to the game here
Yeah.
on this realization. I think for so many of them, they think that stops at the doors of their own call center, and they're not thinking about, what's actually happening day to day in those provider offices
Yeah.
that have probably a lot more impact than what's going on in your own call center. And so it's almost like breaking through the fourth wall, as you would
Mm.
say in television or in movies, and somebody turns and looks right at the camera and speaks to it. That's sort of the whole game with our provider networks now. And, I think simplification for these folks and reducing the burden and, you know, Sachin Jain, who you succeeded there at Caremore, said something incredible on our interview with him a couple of weeks ago. And that was that we need to move more toward monogamy in Medicare Advantage relationships and less and more away from polygamy.
Oh man,
And
he is the best. He comes up with I I wish I could come up with that stuff. That's great.
he's so good at it.
Yeah.
But it's a philosophy I think we all share, which is the simpler we can make these relationships with the providers, um, even to the point of reducing the number of IPAs or big medical groups that you're contracting with so that you can have better collaboration and results, I think that's a very important message these days.
Extremely. Yeah, that really resonates. I mean, going deeper, forming longer relationships so you're not sort of bound by the traditional contract cycle, squeezing out some of the inefficiencies that I have felt in my career on lower performing networks,
Hmm.
which at the end of the day, I think is a little bit of what V28 was probably trying to do, if not explicitly, then at least implicitly. I think that will bring a level of simplification so long as, the big players are willing to do it, and that requires trust.
Yeah.
And we're very lucky to have a good relationship with our payers, including Scan and Elevance and others that hopefully will allow for that move closer to monogamy. I really like that.
Yeah. It was a great point. And, despite the acquisition by Elevance, you guys seem to have enjoyed a relatively hands-off relationship with them, right? Where they still allow you a fair degree of autonomy as opposed
Oh,
to other acquisitions.
well, good point of clarification. So, Caremore is actually independent again. So, Elevance is still an important partner and investor, but Caremore at the end of 2024 became an independent medical group again. We're under the Mosaic Health platform with some great sponsors and investors, and yeah, to your point, which is exactly right, the ability to do what's right for the provider, for the patient, to have that level of autonomy to say, hey, we're gonna really get after like these three things, and we know that there's some other stuff that we're just not gonna chase, is one, it's more fun, and two, I
Yeah.
think it leads to the right outcomes both clinically and economically.
So that puts you squarely kind of in the middle market, if you will, not the Uniteds and Humanas and the Kaisers and, not the little dinky local guys, but in that middle market. And, one of our first guests was Cece Connolly from the Alliance for Community Health Plans.
Oh, very good.
And Cece, rightly points out that the middle market is really struggling right now, especially in this rate environment that we're sailing into in 2027. You know, if you were sitting in a meeting with the middle market plans and given the experience that you've got, what would be a couple of the key pieces of advice you would give to those middle market plans for how to survive in this new age of austerity we find ourselves in?
Yeah, that's a great one. Clinical outcomes are all that matter. That would be one. Two, scale is hard. And
Scale
so
is so hard. Yeah.
really, really getting focused on where do we need standardization? Where are we going to make our strategic bets on this is the platform. This is why the platform is going to be able to support, growth no matter where we are.
Yeah.
Um, and getting those bets right.
Yeah.
So getting conviction around them, I think
Yeah.
is critically important. And then how do you have the discipline to really understand your competitive advantage in the local markets? So there's always this tension between, scale and standardization, and healthcare is intrinsically local. And I think, if you're not one of the big 800-pound gorillas in the room, really getting conviction around this is why we think we're going to win here and what we have to do, even as we
Hmm.
build the right platforms to get scale,
Hmm.
I think is a critical conversation.
Yeah. Absolutely.
But
Thanks.
Unmesh, I'm curious. I mean, you live and breathe this. I mean, how do you think about scale, and what advice would you give me and others in the similar boat?
Yeah. Well, the way I see it is back in the day, and I would say even like 3 years back, Medicare Advantage was a party. At least that's what we saw. And scale, the way organizations thought about scale was simply throwing people at problems, and the more people you throw, the more you can scale was kind of the way to go, because there were financial incentives aligned to that as well. What I've seen, just like you guys were talking about with the changes in version 28, with more focus on quality, going back to the basics of utilization, that you have to keep your MLR and utilization managed, otherwise you cannot scale. I think the financial environment is that now. And the only way to scale is not thinking that you're going to throw people at every problem. I think that's why, just like you said, operational rigor is important, but at the same time, providing the right data, the right technology, the right automations at different, areas, whether it be the back office MSO, care management, disease management, claims, utilization management, whether it be data platform, like, back in the day, you had large data warehouse teams who were, ingesting data from all these places. You used to have these large teams, large data warehouses. All of that has changed with
Hmm.
the onset of AI. Technology is now becoming simpler and the go-to-market is faster. So I feel like that embedding of technology at the right places within the org can help you not throw people at every problem. Sam, I want to talk to you, man. Like, you've been operating for so long, and you cannot operate for so long in small, big, medium teams if you don't have a playbook. And I use that word very carefully, because in healthcare, no playbook works. The playbook keeps changing. Um, but what separates like a very well executing organization, which is scaling up over time with the right structure, from an operational rigor perspective versus, the others? What are your thoughts there? You've ran some very successful national and regional operations.
And I've failed a bunch as well, and run some not so successful ones, which
We'll
I
get to that.
probably learned. Yeah, I had a feeling. For me, one of my key words, and we use it again intentionally during our meetings, is clarity. Can you get to a point where everybody on the team and down through your functioning, clinical and operations lanes really understands with clarity, this is what we're doing and this is what we're trying to accomplish? And what that really focuses, hey, how simple can we make this? How can we wring out sort of the complexity and get to the most crystallized form of this is what we have to do, this is what we think the outcome is going to be, and here's how we're going to measure against it, and then have the rigor and discipline to do that and iterate as needed. And then, how do you bring that into practice? So if any of my team listens to this, they will laugh when I say this, but I believe very, very strongly in what I call management process. And that basically means to me, how you choose to spend your time is where you're going to be successful. And so you have to be very mindful of what meetings are you having? What are you talking about? What reports are you reviewing? And you've got to be willing to do that day in, day out, because one of the hardest things that I've experienced within healthcare services, value-based care, or whatever you want to call it, is you can't do something just once. Like, the hardest part is you've got to show up and you've got to do it every day, every week, every month.
Yeah.
And that's the playbook in Mesh, right? That's, hey, here's what we care about. Here's how we're going to measure it. Here's how we're going to make sure we're spending our time on those things. And we're committing to doing it on a set cadence. And so the playbook keeps changing, but I think, those are lessons that I've learned sometimes the hard way, that are going to be pretty timeless.
I'm going to take a snippet of this and I'm going to distribute that with my operators within my
Perfect.
team, because it's so spot on.
I'm sorry to your team ahead of time. This is all my fault.
Well, it's
Well,
a great conversation around scale. So, as we may have mentioned, we almost called this podcast Curitics Confessions, Sam, and we ask all of our guests to share an epic fail or a lesson learned that that really helped to define who you are as a person and as an executive, and your whole vision for how you drive change in this industry. So, can we ask you for one of your confessions?
Absolutely. Yeah, it's really, really cool that you ask guests this. Like I said, I believe, you're gonna learn more from that
You'll
stuff
learn a
than
lot
you are
more.
from your successes. And it's great to be able to create a space to talk about them and share them with other leaders, because, before I answer it, I'll say, we all need to be heavily invested in creating the newest set of leaders in this industry. We're going to need them. And, I try to do my part, and I'm very grateful for all the talent that has flown sort of into this industry, and we've got to do our best to invest in it and protect it. And with that, I will answer the question. I think the one that comes to mind for me, John, is back to this idea of how important specialty network is. And, you can look, there are a number of times where I had to make a decision on making a big change in where our attributed population would go for very, very critical specialty care. And on the paper, it can look so easy. It can be, hey, you can just go subcap with, specialty group X, and you're going to save Y $1 million per year. Like, how hard could that be? And the truth is, it's incredibly hard. And I can remember at least 2 instances where we made, what I believe to be the right decision to change Align Specialty Network. And because I didn't approach it with enough respect, because we didn't put enough sort of weight on change management and really making sure that our providers and our patients knew why this was going to be important to them and how it was going to result in, more affordable, better access, better outcomes. We just sort of, said, oh, of course, this is the right thing to do. I can think of 2 instances where I just got creamed, man. I mean, not quite providers picketing out front of my office, but not far from it. And, heartbreaking patient letters who are concerned, what was this going to mean for their care? And if I could go back and do it again, I would take much more care in how I approached those changes to make sure that I was really bringing along the stakeholders that matter, which are the providers and the patients, and that I would do a much better job of making sure that they understood that this was going to be a positive, explaining that, making sure that they had that warm handoff. Those were some very, very formative experiences that I would qualify as epic fails.
Yeah. And it's a fallacy that I think is common among attorneys like you, Sam, isn't it? Which is COIC, clear only if known.
Oh, I've been out of the game a long time. I don't know that one, but it's not just attorneys. I think it's anyone who doesn't pay enough attention to really what happens within the industry. You can look at something on a slide or a spreadsheet, and it can seem so perfectly clear. But executing against it and understanding that at the end of the day, you're dealing with patients' lives and providers' livelihoods. Like you can't, if you forget that, you're gonna wear it.
Yeah. Great point. Great point, Sam. Thank you. Yeah. Well, Sam, thank you so much for joining us and for sharing all your perspectives with us today. And thank you to everyone listening to Curitics Conversations. You can follow us on YouTube, Podbean, Apple Podcasts, and Spotify.
Excellent.
Thank you, guys.
Thank you, Sam.
Thank you, Sam. And thanks again for listening. We'll see you all next time.